Hello, everyone. Welcome, welcome. Free webinar Friday. Excited you're here. If someone can let me know if you can see me okay, you can hear me okay, that would be lovely. Looks like everyone is hearing well. Perfect. That makes things a little bit easier. Well, awesome. Welcome. We're so glad you're here. Today we are talking all things maternity. My name is Jennifer Bonner. I am a certified nurse midwife. I've been a nurse for over 15 years now. I've worked anywhere from ICU to in-hospital endoscopy, labor and delivery. I worked as a certified nurse midwife in a private client here or in a private clinic here where I live for about 4 years before I jumped into education, and I absolutely love what I do. So I function as the lead tutor here at Archer Review, and I am passionate about working with our students. So those times when we see those light bulb moments, that is what I'm striving for. So I'm excited that you're here. Let's go over a few housekeeping rules before we get started. So you will notice that there is a Q&A and a chat if you are in the Zoom. If you can use the Q&A for your questions. We have the lovely Rachel Taylor joining us. She is here on both Facebook, Zoom, and YouTube. So please be patient with her. There are a lot of you and just one of her. So she is very quick to get to questions, but just give her a little bit of grace as she works through those. So today what we're going to do is we're going to work through a case study. One of the great things about a case study is that it gives you a kind of a grasp on how to apply the information that you know, how to put it into real world situations, which is amazing. So if you're ever struggling with a subject, throw it into a case study. It's really going to help you kind of solidify that information. So if you are not familiar with our free webinars, we use what's called Slido. And so you can join by using your smart device and hovering it over our QR code here. It will take you to where we are. If you cannot and you want to use a different device, you can log into slido.com and you're going to put in the code maternity with Archer, and that will get you in for our Slidos today. So we'll do questions throughout. Feel free to join me there. I'm seeing a lot of Canada. That is lovely. Welcome, welcome. South Carolina, Toronto, Alabama, USA, welcome. Florida, Denver. Hey, you're not too far away. Ghana, welcome. Los Angeles, Calgary, Michigan. Fabulous. We have people from all over. Well, let's go ahead and get started. We're just going to jump right in and we're going to go ahead and meet our client. So Mrs. Jones is a 31-year-old female. She calls her OB provider and she says she thinks she might be pregnant. She's had a positive pregnancy test. She's really tired and she's lacking some energy. So jump back into Slido. Tell me what sign of pregnancy is a positive pregnancy test. Remember, there's 3 different signs of pregnancy. Is it presumptive, probable, or positive? Which one do you think a positive pregnancy is? Positive pregnancy test. So this is one that's done at home. So I'm seeing going probable, positive, or probable, presumptive, but we see them all represented here. Seeing probable, probable. All right, I'm seeing a little bit of everything. So let's look. The answer is actually probable. So let's visit our signs of pregnancy. So there's 3 different signs that we're going to talk about. We're going to talk about presumptive. We're going to talk about positive and probable. Okay, not necessarily in that order. So presumptive, I want you to think that we presume you are pregnant or we presume the client is pregnant. Now, these are things like period is absent, amenorrhea, really tired, enlarged breasts, sore breasts, urinating frequency, movement perceived, or what we call that quickening, emesis and nausea. Now, there's a few different things that we notice about these symptoms is that they can be attributed to other issues, right? So we know with people that have polycystic ovarian syndrome or PCOS, they can have amenorrhea. They can go months without a period. People who are really tired, raise your hand if that is you. If you're in nursing school, I would wager a guess that you are probably really tired. If someone just had a new baby, they may be really tired. If someone is really stressed out, or um, maybe they are depressed, they may feel really tired. There's a lot of different reasons why these symptoms might occur. Sore breasts, maybe there was a trauma. Maybe there's something else going on. Um, Urination frequency. A lot of times we attribute that to a UTI, right? If they're going more frequently. Nausea and emesis, maybe they have picked up a tummy bug. That could be one of the issues. Now, the next one is probable. When I see probable, I think you are probably pregnant. Now, these are things that are more likely than not due to pregnancy. It's not definitive. It means there could possibly be something else, but chances are, if we are seeing these signs, you are probably pregnant. Now, these are things like a positive pregnancy test. There are very few other things that can cause a positive pregnancy test. One of those things is certain cancers can do that. Um, but more so than not, if you're getting a positive pregnancy test, you are probably pregnant. Return a fetus when tapped. We call this ballottement. So when a provider taps on the fetus and it comes back down, chances are that's probably a baby and not something else. If you're seeing the outline of a fetus on the belly, chances are it's a baby. Braxton Hicks contraction, softening of the cervix. We call that Goodell sign, where the cervix starts to soften up. The bluish coloring to the cervix and the vaginal area, we call that Chadwick sign. That is a probable sign of pregnancy. Also, things like the lower uterine segment is softening. So when we think about the uterus, let's see if I can do this. Actually, look. Look at this. All right, let's see if I can get this to where you can see it. Okay, so we have nope, there we go. We have the uterus. This is not going to work for me. There we go. So this top part, it kind of looks like an upside down pear. Okay, so top part is bigger. We funnel down to the bottom. So this bottom portion becomes softened. Okay. And then an enlarged uterus. A lot of times that's due to a pregnancy, but other times it could be to some type of tumor. That was my cuterus, by the way. So hope you enjoyed that. The next one that we're going to visit is positive signs of pregnancy. Now, this is without a doubt, you are definitely pregnant. We are positive you are pregnant. And these are things like we are seeing fetal movement that's felt by the provider, electronic devices picking up that baby's heartbeat like a Doppler or an ultrasound. If the baby delivers, you were positively pregnant. Ultrasounds, seeing the movement of that baby, those are positive signs of pregnancy. So you definitely want to know those different signs, the probable, presumptive, probable, presumptive, and positive. All right, so the nurse asks Mrs. Jones, when was your last menstrual period? And she says it was 10, 25, 22. So with an LMP of 10, 25, 22, what do we expect her expected due date to be? Jump into Slido. The code should be all lowercase. Maternity with Archer if you're joining on slido.com. Someone is asking what to do if your ATT has expired. You will need to apply for a new ATT code. Great question. So I'm seeing a lot of July 18th, July 22nd. July 31st, August 1st, July 1st. I'm seeing May. Okay. A lot of different options here. All right, let's check out the Q&A. I'm seeing some July, I'm seeing some August. So our last menstrual period is 10/25/22. 10/25/22. All right. So when we are trying to determine the expected due date, we want to use something called Nagel's rule. This is absolutely something that you should know. I definitely want you to commit this to memory. I want you to use this. I am someone that I enjoy math, so this is one of my very favorite things to do. I could do questions on Nagel's rule all day long. So what we're going to do is we're going to take the first day of the last menstrual period. So that was 10/25/22. We're going to add 7 days. We're going to subtract 3 months, and then we're going to change the year if necessary. Okay? And that's going to give us our estimated due date. So let's look at that together. So our last menstrual period we said was 10/25/22. So we're going to add 7 days. So that gets us to 11/1/22. Now here's something to remember. If this is something I learned in elementary school and I sing it all the time. 30 days have September, April, June, and November. All the rest have 31 except February that has 28. Okay, so we need to remember which days have 30 days, which days have 31, which days have 28. Or which months, I apologize, which months have 28. So we add 7 days to 10/25, and that puts us November 1st of 22. We're going to subtract 3 months, and that gives us 8/1/22. And we're going to add the year, so 8/1/23. So if you answered 8/1/23, you were correct. Great job. All right, here's another question. Now, what if the LMP would have been in January of 22? Would the year for her due date still change? What do you think? Saying yes. Seeing a bunches of yeses. Same year. Oh, I'm seeing some no's. Oh man. We're seeing some yeses, we're seeing some no's. Okay, are you ready for the answer? The answer is no. The year would not change. It would still be due in January or in 2022. So if her LMP was in January, when we subtract 3 months, that puts us into December, November, October, which is still in the same year. So January to February to March, April, May, June, July, August, September, October would be 9 months later, and it would still be the same year. So kind of be thinking through that as you're working through Nagel's rule. That will help you quite a bit. All right, so we're going to jump into some weekly developmental milestones during pregnancy. I think it's always fun to see kind of what's going on in pregnancy as that fetus is developing. So it's determined that Mrs. Jones is now 11 weeks gestation. So what developmental milestones have occurred by this time? Excuse me. What kind of developmental milestones do you think could have happened by this time? Neural tube development. Okay, that's a good one. That's a really good reason why we want our clients to be taking their folic acid before this time, right? Because that neurotube development is already taking place. So we want that on board. Heartbeat, neurodevelopment. We can hear the heartbeat. Okay. Yeah. Those are big ones. So by 11 weeks of pregnancy, that developing fetus has gone through a lot of different milestones, and it's transitioning from the embryonic stage to the fetal stage. So a couple of key fetal milestones that I want you to think of by 11 weeks of gestation. Organ formation. So most of those major organs and those major organ systems have already started forming during that embryonic stage and by 11 weeks. Many of them have already developed to some extent, but they can continue to mature and develop throughout the pregnancy. Fetal heartbeat. Many of you mentioned fetal heartbeat. Excellent job. It has developed and it's beating steadily. It's usually detectable through ultrasound by this time. And you may even hear the baby's heartbeat during a prenatal appointment. So a lot of times when we would have clients come in and they were around 11 weeks, in theory, I should be able to hear that baby's heartbeat with a Doppler. But there are some times, depending on body habitus, kind of where that baby is, that occasionally we aren't able to pick it up with the Doppler. And so I'll just let them know, hey, we're going to try to hear baby's heartbeat today with the Doppler. If I can't, no worries at all. I'm just going to take you down the hallway. We'll do a quick ultrasound, make sure everything's okay. Fingers and toes. The fingers and the toes of that fetus have formed and they're no longer webbed. So they're separated. Their tiny nails are beginning to develop. It is just moving right along. Facial features are becoming more defined. The eyes, the nose, the mouth are in their right spots, and the eyelids are starting to cover the eyes. Limb movement. The baby, the fetus, is capable of making small, involuntary movements of its arms and legs, but these movements are not typically felt by the mother until later on in pregnancy. The fetus's sexual organs have formed, but it can still be challenging to determine the baby's gender through ultrasound at this point because they look very similar. It can usually be identified with greater certainty during that second trimester. By 11 weeks, the external genitalia are beginning to differentiate and develop, but not fully distinguishable. All right. So let me just give a shout out to our small group tutoring. This is one of my very favorite ways to learn. And it reminds me of kind of study groups when I was in college. We would form, a small group of 10 of us, maybe. We'd divide up the study guide and we would just kind of sit around and chat and talk through study together. Now, our small groups are covering a lot of different information. So they are $25 for an hour, which is great rate for information. We're looking at practice questions. We are talking about how to answer questions and also very different information. So all of our tutors, they offer different selections. So you can scan the code here and that will show you kind of what's out there. We have everything from practice NCLEXs to maternity, labor and delivery, mental health, pharmacology, EKGs, you name it, we've got it. If there's something that you're not seeing that you would really like to see, please don't hesitate to send us an email at nclextutors@archerreview.com. We're happy to help where we can. All right, so that first trimester, within the first month, as that developing, as that egg is starting to grow, it forms a watertight sac around it, and it's creating the amniotic sac. The placenta is developing, the face is forming, the heart tube's developing. Then we jump into the second month, so that's weeks 5 through 8. Remember, in pregnancy, we are assuming each month has 4 weeks in it. Those facial features are continuing to develop. The neurotube is well formed, and at 6 weeks, the heartbeat can be detected through ultrasound. In month 3, that 8th week, the baby is referred to as a fetus instead of the embryo. We have hands, arms, fingers, feet, toes, all those are fully developed. They're starting to explore opening, closing their fists, opening and closing their mouth. Now, most of that fetal development is taking place, or most of the development is occurring in that first trimester. So by the end of the 3rd month, most of that stuff is done. Therefore, the risk of miscarriage goes down pretty significantly. So a lot of women are able to take that big at the end of the first trimester. It doesn't mean that it's never happened before. It doesn't mean that it's not possible, but that risk certainly goes way down after the first trimester. All right, so we need to calculate Mrs. Jones's GTPAL. She tells us that along with this current pregnancy, she has a history of a healthy delivery at 38 weeks, an emergency C-section at 29 weeks where the child did not survive. Now, GTPAL, again, I'm one of those really weird anomalies that I love this stuff. I love Nagel's rule. I love GTPAL. I just find it really interesting. So Mrs. Jones, she's here for her prenatal. She had a healthy delivery at 38 weeks. She had an emergency C-section at 29 weeks where the child did not make it. So jump back into Slido and tell me, what is Mrs. Jones' GTPAL? What do you think? So my question is, what is Mrs. Jones' GTPAL? So she's here for her prenatal appointment. She had a 38-week pregnancy, um, healthy delivery at 38 weeks, an emergency C-section at 29, and the baby did not make it. What do you think? Seeing some G3s. I'm seeing a lot of G3s. Seeing some G2s. Okay. G3s. Okay, well, let's talk through this one. So our answer is G3, T1, P1, A0, L1. So let's talk through this one. So Mrs. Jones is here because she's pregnant, right? So that counts as one. And this is a lot of times where we get caught up is we forget that she's actually pregnant right now, and that actually counts. So she's pregnant now, a 38 weeker and a 29 weeker. So she's been pregnant now 3 times. Now, the only term pregnancy she had was that 38 weeker. Her preterm, now remember, term is considered 37 weeks. So anything before 37 weeks. So if it's 36 and 6, 36 weeks, 6 days, that is preterm. But it has to be after 20 weeks. Okay. So she had that 29 weeker, that counts as preterm. Abortions are anything before 20 weeks. She doesn't have any of those, and she has one living child. So if you got G3, T1, P1, A0, L1, you are correct. Excellent job. All right, so let's break this down. Let's talk about gravidity. Gravidity, besides being a great word to say over and over again, this is the number of pregnancies that the woman has had. And remember, it counts the current pregnancy as well. Okay, that current pregnancy is definitely going to count here. Twins, they only count once. It's one pregnancy. Okay, so gravidity, G, total number of pregnancies counts the current one. Twins count as one. Term. Now, these are term deliveries. Okay. So, number of pregnancies carried to term. So, term is 37 weeks and beyond. Okay. So, 37 weeks on up is considered term. Twins, again, they're only counting as once. Twins are only counting as once here. So, term is 37 weeks and beyond. Twins are only counting as once. Now, I just had a question. Someone was asking, would the NCLEX be that specific? Like saying her last child was born at 36 weeks and 6 days. They absolutely could be that specific. Just making sure that you understand that term is not until 37 weeks. All right, what about preterm? Preterm is the number of preterm births. So we just talked about term being 37 weeks. So before 37 weeks, but after 20 weeks is considered preterm gestation. And again, our twins are only counting once here. Okay, so anywhere from 20 weeks to 36 weeks and 6 days is considered preterm. Now, what about abortions? Abortions gets a little complicated because we're talking about elective therapeutic abortions. We're also talking about miscarriages here. This is the number of pregnancies that ended before 20 weeks. Okay. So 19 weeks and 19 weeks and 6 days. So if someone is asking if the question says it was a miscarriage after 29 weeks, that would actually be counted as an intrauterine fetal demise. And that would not count as an abortion. It would count as preterm because it's after that 20 weeks. Okay. So this is the number of pregnancies that are ending prior to 20 weeks, so 19 weeks and 6 days. This can be a spontaneous, like a miscarriage. It can be a termination, like an elective abortion or a therapeutic abortion. If it was after 20 weeks, it's included under the P's. Living children, this one's pretty self-explanatory, but finally the twins get their day. This is where twins are actually going to count twice. So living children, total number of living children currently. Now, something to think about is this can change from year to year. So generally working in an OB clinic, this is one of the things that we want to know. We want to know what are our clients' G's and P's. And there have been times when those numbers have changed from year to year. Last year it was she had living of 3. This year it's living of 2. Someone is saying they have their exam on the 30th. We are cheering you on. You can do this. We are excited for you. All right, so back to Slido. Mrs. Jones states she's concerned about her nutritional needs now that she's pregnant. What nutritional needs would we want to educate her on? What do you think? What nutritional needs would we want to educate Mrs. Jones about? I'm seeing folic acid. I'm seeing iron, prenatal vitamins, absolutely, folic acid. Water, absolutely. I'm seeing high protein, folic acid. I'm seeing some iron. I'm seeing a lot of iron. A lot of you are talking about iron, calcium, multivitamins, prenatals, high protein. Excellent. So when it comes to pregnancy, there's a few different things that we need to talk about. Pregnant women generally need about 300 additional calories per day to support that growing fetus. So this is one thing is that people who are trying to lose weight, we do not recommend that you're doing that while you're pregnant because baby needs those extra calories. Now, a lot of people will take that, I'm eating for 2, a little bit too far. We don't necessarily want you doing that, but we do make sure that you're getting some additional calories on top of what is normally recommended. So just a shout out here. I have a few people asking how they can access the recording after we're finished. The recording will be available on our Facebook page for you to be able to view after we're finished. So we want to talk about a few different things. Proteins, lean options are ideal. So like dairy, eggs, lean proteins like white meats, things like that, is going to help with fetal growth, especially that muscle and tissue. Complex carbs, whole grains. I saw many of you were talking about complex carbs, starchy vegetables. These are going to help with energy. Okay. And we want to avoid the simple carbs because that can really increase the blood sugar. So our gestational diabetics, our type 1s, we definitely want to consider that. Fiber, complex carbs, we find this in plant foods and legumes. This is going to help with healthy digestion. And then those healthy fats. These are important for energy with mom and developing those fetal organs, the placenta. And so we see things like avocados, nuts, seeds, fish, but we want to be very cautious with fish. So we want to avoid the fish that are high in mercury. So these are things like big eye tuna, mackerel, swordfish, shark are really big. The other thing is even fish that are normally low in mercury, if they're coming from an area that is has water has a lot of mercury in it, we want to be very careful. Oily fish are our best, so like fresh tuna, mackerel, sardines, but we're going to limit those to about 2 portions per week. So mom still gets to enjoy her fish. We're just going to be very careful with it. Now, a couple of you, and by couple, I mean many of you, had mentioned iron, calcium, folic acid, taking those prenatal vitamins. So folic acid in higher doses for multiples or in higher risk pregnancies, we definitely want them to be taking that. And remember earlier we talked about ideally we want our client to be taking this before they get pregnant so that it's on board as the neurotube is developing. And it's going to help prevent those birth defects of the spine and the brain. But remember, by the end of the first trimester, a lot of that has occurred. Calcium, think about what we talk about. Growing up, I learned that milk is good for your bones, right? They wanted you drinking your calcium. So it's good for fetal bone development, teeth development, strengthening, and important for mom's maternal health as well. Vitamin D helps build those fetal bones and those teeth. Iron for mom to increase blood and oxygen carrying capacity to support that baby. So these are things like fatty fish, salmon, fortified milk, and fortified orange juice. Those can be really great foods for mom to use. For vitamin D, for iron, meat, beans, and we want to make sure that we take it with a vitamin-rich food. So a lot of times, if a mom is taking a supplement, a supplemental iron, I'll tell her take it with a couple chewable vitamin C's. It'll help with absorption. DHA, we typically take that in a supplement, but it is also an oily fish. It's an omega-3 fatty acid, important for eye and brain development in that fetus. And then also iodine for fetal brain and nerve growth. Salt is now iodized, so it's rarely an issue anymore, but we a lot of times find this in our animal proteins like beef liver, chicken, fish, things like that. Now, when we talk about things that we um, should be doing in pregnancy, we also need to talk about the things that we should avoid. So we talked about some of these already, fish that are high in mercury. So basically, if we have high mercury, that can affect the development of the nervous system, the kidneys, the lungs. So these are things like shark, swordfish, king mackerel, big-eyed tuna, things like that. We want to be careful with cold deli meats, hot dogs. That's not to say that mom can't still have those things, but what we recommend is that they are cooked to where they're steamy to help get rid of the bacteria that could be there. Raw meats, raw eggs. Again, being careful with the bacteria, pate and liver. So this is high in vitamin A, and at high levels, this can cause congenital defects in the cardiac system and also the central nervous system. It can also actually increase the risk for spontaneous miscarriage. So we want to be very careful there. Caffeine, whoo, man, that's one of those, um, man, it's a bummer sometimes giving up the caffeine, but no more than 12 ounces of coffee per day. So mom can still have a cup, not a problem, but we let's stop with 1 cup. More than that can lead to placental umbilical cord vasoconstriction. So think about clamping down on that cord, baby's not getting what they need. So that can be a real problem. And that can decrease fetal oxygenation. And we need that baby getting all the oxygen. Also being careful with unwashed produce, seeing things that can crawl on them and the bacteria and the pesticides and things. We want to make sure that we're not ingesting that. Alcohol, it should go without saying. There have been research that's kind of gone both ways. A little bit's okay, but we don't know how much. So we just say at high doses, it can cause fetal alcohol syndrome. That can cause a lot of different deformities, growth issues, vision issues, learning disabilities. So we just say, how about let's just not? Okay, no alcohol during pregnancy. All right, I had a question about this earlier. Um, Private tutoring. So this is a little bit different from, actually, it's not a little bit different. It's quite different from the small group tutoring. This is where you get 1 hour to you and a private tutor. It's just the two of you. It's completely individualized. So I've had a lot of students that have jumped on and they said, Jennifer, I just failed my NCLEX. I have no idea what to do. And so we spend a lot of that time going through your report on what you need to look at and where you were in regards to that passing standard, developing a plan, setting up a study schedule, talking about how to be successful, how to take test questions. A lot of times, if we get those basics down, a lot of the other things will come. Talking about how to manage anxiety and things that come up as we're taking the test. So scan the QR code. We have amazing private tutors out there. There's a lot of availability. I just checked today. There's quite a bit out there for you. If there's a day, so let's say you're saying, you know what, I'm looking at my calendar. I really need a private tutoring session on Monday, but I only have between the hours of 8 a.m. and 12 p.m., but I'm not seeing anything there. Send us an email at NCLEX-tutors@archerreview.com. Let me know. First of all, I need to know where you are. So give me your um, the time where you are. So Eastern Standard, Central, Mountain, Pacific, whatever it is. Let me know, and then let me know what times you need, and we'll try to see what we can do to help you. We are all about our student success and walking alongside with you, and we love hearing your success stories. So scan the code, see what's out there, and we're looking forward to working with you. All right. So 2 weeks later, Mrs. Jones calls and she says she can't keep anything down, including fluids. No good. So what are we concerned about? So the small group tutorings are not, they are recorded, but only for quality purposes, but they're not sent out. So what are we concerned about with Mrs. Jones? She can't keep down anything, including fluids. I'm seeing dehydration. Aha, there it is. I see it. Hyperemesis gravidarum. I see electrolyte imbalances, poor nutrition, fluid overload, vomiting, electrolyte imbalances, dehydration. I'm seeing a lot of great answers. The one I'm looking for is hyperemesis gravidarum. Now, hyperemesis gravidarum is very significant. It's something that we need to take seriously, but is very different from morning sickness. So let's visit morning sickness for just a minute. Morning sickness is nausea. It can have vomiting that goes with it, but it generally subsides. Many women have their fingers crossed it's going to subside after that first trimester, but generally after 20 weeks. If it's going after 20 weeks, we start to wonder, is there a thyroid problem or something else going on? But that vomiting generally doesn't cause dehydration because generally they're able to keep something down. Some food, some water, just not everything. Hyperemesis gravidarum is extreme morning sickness. It's way off the charts. It's that intense. It's um, nausea and vomiting. It's hard to keep anything down. So this nausea and this vomiting does not subside. It just kind of lingers. And it can cause dehydration, like many of you suggested. It can cause weight loss, electrolyte imbalances, which I saw a lot of that in your responses. And this can be a real problem because we need mom to be taking in nutrition for that fetus that she's growing, right? So when do we get concerned? Well, we want to know, are you losing weight? So that's why we're weighing every visit. We want to see, are we gaining too much? Are we not gaining enough? What's going on? Also, are they dehydrated? Now, think back to just the primary, maybe your first class in nursing school where you're learning to do a good health assessment. How do we determine dehydration? We're looking at skin turgor, right? Do we have tenting or does it go right back down? Mucous membranes. So looking at their mucous membranes, are they pink? Are they moist? And what's that heart rate doing? So when we become dehydrated, the heart's going to speed up and try to compensate for not enough fluid. The other thing we're looking at are electrolytes. When we see dehydration, we're seeing hypernatremia. So the body's trying to hold on to what it can. When we have that excessive vomiting, a lot of times we'll see hypokalemia, hypochloremia, those types of things. So we can even visit their labs and just see how are they doing electrolyte wise. And then we're doing a really good assessment to determine, are they dehydrated? So that's when I get concerned. If they're losing weight and they look icky, we need to do something and we need to do something pretty quick. Now, when it comes to management, there's a few different things we can do, and we don't always have to go right to medications. We can try some just very generic things that we can see if they can help, just things that they can do at home. So things like sitting up after meals to try to help just gravity get that fluid, that those meals down. Eating a few crackers before getting out of bed, just having something on the stomach as they start about their day can be helpful. So a lot of times I'll just have people keep crackers at their bedside before they get out of the bed. They can just munch on small portions of meals. So generally what we do is we eat a big breakfast, a big lunch, and maybe even a bigger dinner. But for these women, what we want them to do is we want to do small, frequent meals throughout the day because we don't want them getting too much and then throwing it back up. And a lot of times, what we do is when we eat those big meals, we're drinking along the way. For these women, we're going to recommend that they do not take liquids with their meals, but they're going to drink in between. And a lot of times, I tell them, get a straw. A straw helps you be able to control a little bit better how much fluid is in your mouth. And generally, they do a little bit better with that. Nothing too hot, nothing too spicy, nothing too cold, just kind of very generic. Now, if that's not working, we look at promethazine. So we're going to do a risk benefit assessment that really the decision to use any medication during pregnancy is going to involve a really careful assessment of the risks and the benefits. Nausea and vomiting during pregnancy, so like morning sickness, are common, and most cases they don't require medication. Just some lifestyle changes can be really helpful. Ginger candies, that water after meals instead of with meals. Medications are typically considered when those symptoms are severe, and they're actually impacting the woman's well-being. So they're losing weight, they're dehydrated, their electrolyte imbalances. We're going to look at promethazine. So in this class of medications, it's called our antihistamines. It's been used for many, many years to treat nausea and vomiting in pregnancy, and it has a relatively long history of use. It's a lot of times we consider it safe when used appropriately under, appropriate medical supervision. But like all medications, it's not without potential side effects. Someone is asking if we give other medications, and absolutely we can try other ones, but we want to be considerate of the pregnancy category. So a lot of times we'll start here, and then if we need something else, we can go use something else as well. Ginger, yes, ginger candies are helpful. Those can certainly be used. Ginger ale. They make these things called gingies. They're like a almost like a Laffy Taffy, but in ginger. And a lot of times those that will just settle the stomach right down. So a lot of women use those as well. Other medications that treat nausea and vomiting during pregnancy, B6. A lot of times I would have women use vitamin B6 and Unisom and put those together, and those seem to do really well. They're often used as recommended as first line treatments because they have better safety profiles. But the choice of medication can vary depending on the individual's medical history, what they have going on, their specific circumstances. Some women respond to one medication better than another, and that's totally okay. So, again, individualized care. We can look at dietary changes, acupressure, lifestyle modifications. All of those things can definitely be assessed and talked about at to help the client make an informed decision. If these are not working, a lot of times we take mom and we bring her into the hospital for IV fluids, and then if it's really, really bad and these things aren't working, TPN is the next thing we're looking at. So at 28 weeks, Mrs. Jones' vomiting is finally under control. I bet she is excited. Her provider tells her it's time to do a glucose tolerance test. Woo! If you have ever had a glucose tolerance test, man, it is something. It's like drinking a Hawaiian punch that's super, super sweet. So someone is asking about avoiding certain medications. So we want to be considerate of the pregnancy class for each medication that we use. So we want to use what is safest for our client. So when we are talking about the oral glucose tolerance test, this is done at 28 weeks. And generally, this is done for everybody. I always get the question, well, what if they are a type 1 or a type 2 diabetic? We generally don't go ahead and do this because we already know they're diabetic. This is trying to pick up gestational diabetes or diabetes during pregnancy. So we do this at 28 weeks. Mom's going to drink a bottle of what's called glucola generally. Other facilities have different ways of doing it. We had alternatives at our clinic where we would give a certain number of a certain type of jelly bean and mom could eat those, but we need 50 grams of that oral solution. An hour later, we check the blood sugar. If it's greater than 140, mom gets a 3-hour glucose tolerance test or a glucose tolerance test. So one thing to think about here is that mom doesn't need to be fasting for this, which is Really helpful. But when we do the 3 hour, she definitely does need to be fasting, generally for 8 hours prior to this test. So if we fail the 1 hour, or if there are other risk factors, a lot of times we send mom for a 3 hour, and she's going to fast. We're going to get there. She's going to have her fasting blood sugar checked. They're going to give her generally the same bottle, but it has 100 grams of glucose in it. She drinks that. I think she has generally about 5 minutes or so to drink it. And then we start a timer. So an hour later, we check the blood sugar, 2 hours, and then 3 hours. So if at 1 hour her blood sugar is I'm sorry, if at fasting her blood sugar is less than 95, good. If at 1 hour it's less than 180, good. If at 2 hours less than 155 and 3 hours is less than 140. Now, if two of the other three labs are high, we will make a diagnosis of gestational diabetes. Or if the fasting is greater than 195. Okay, so it could be an either or, it could be all and. I've seen people that have failed all of them at one time or another. All right, so Mrs. Jones' blood glucose, her with the 3 hour test is 163. Do you think she has gestational diabetes? What do you think? Let me know. Mrs. Jones' blood glucose with the 3 hour test is 163. Does she have gestational diabetes? Yes, so we can give metformin during pregnancy for gestational diabetes. That's a great question. So someone's asking about the non-stress test. We don't have a reason for that at this point. So I'm seeing a lot of you say, yes, she has gestational diabetes. So gestational diabetes is diabetes that's diagnosed during pregnancy. So basically the pancreas isn't able to keep up with that increased, or they're not able to deal with the increased insulin requirements of pregnancy. So women who already have increased insulin resistance, so PCOS, polycystic ovarian syndrome, is a really great example there. A lot of them are at risk for gestational diabetes, being overweight, having a sedentary lifestyle, if they've had gestational diabetes in the past, or um, family history of diabetes, if they've had a macrosomic infant, or they are of Black, Hispanic, American Indian, and Asian American ethnicities, those can all increase their risks. So how do we assess this? Well, we just talked a little bit about it, but at about 28 weeks, between 24 to 28, we are looking at a glucose tolerance test, and we're screening for glucose in the urine. So what can happen with gestational diabetes? Gestational diabetes can be very scary. Someone is asking, what is PCOS? PCOS is polycystic ovarian syndrome. These women can get both metformin and insulin if needed, but that is those are prescriptions that the provider is going to um, make the recommendation for. So gestational diabetes, you can have a big baby. So as you know, we're taking in too much sugar, baby is getting bigger and bigger and bigger. And the problem is a lot of times the majority of that weight is coming in their top half. So they can have those big, broad quarterback shoulders, which can make delivery very, very difficult. They can get stuck. Shoulder dystocias are big deals there. Preeclampsia can actually increase the risk of preeclampsia, and hypoglycemia in the baby. Now, this one is a little bit interesting. Um, and we'll talk about why we see hypoglycemia in babies here in just a minute. But a lot of times these babies are going to get delivered earlier than we would prefer because of how big they can get. And we want to safely deliver vaginally if possible. But untreated gestational diabetes increases that risk of stillbirth, increases that risk of C-section or traumatic birth. So the first thing we're going to try to do is if someone is diagnosed with gestational diabetes is we're going to try to control it with diet and exercise, right? We want to try to be prudent, see if we can do it without medications first. Some women are able to do this and some are not. But the thing is, at this point, there are some things that we can control in order to help control the blood sugars. But we could be doing all the things right and just not be able to get our blood sugars under control. So diet, exercise, both of those things are going to be great. They're going to be monitoring their blood sugars. Um, so generally fasting and then 2 hour postprandials, 1 hour postprandials after meals. Mom should not require insulin or anything after delivery. Once delivery occurs, gestational diabetes is over, but we do still, we'll still screen her postpartum to make sure that she doesn't have full-blown diabetes because this certainly can increase her risk. Now, we talked about how babies can have hypoglycemia, especially when they're born to mothers of gestational diabetes. So basically, what happens is mom has high glucose in her blood. So baby's been getting all of that blood sugar while they've been in the uterus, right? Well, now all of a sudden they're born and they're not receiving all of that blood sugar, right? They're not getting all that blood sugar from mom anymore, but they're still producing enough to take care of that blood sugar. And so we can actually see them produce too much, and then we can have hypoglycemia. So that pancreas, it's making its own insulin and it's doing a really good job. But once that high supply of glucose goes away, the pancreas is still producing all of that, and that can cause some hypoglycemia. All right, so Mrs. Jones gets her blood glucose managed with insulin. Okay, she states she finally feels better at this point and will see us at her next appointment in 2 weeks. Excellent. Sounds like it went well. We got Mrs. Jones well on her way. She's using that insulin. Hopefully that's going to go well, and we wish her and her baby well in delivery. The last thing that I want to talk about is our number one recommended package is the SurePass combo. This is by far my favorite product. I wish this was available when I was in nursing school, but basically it is a package. It's like a great Christmas present. There's on-demand videos where you can go if you're struggling with, I don't know, gestational diabetes or diabetes type 1. You can go into the on-demand section of our package here. You can watch a video on endocrine. You can watch a video on mental health, on labor and delivery. All of those things are available at your fingertips. We have a Q bank with thousands of questions in there. That you can take, and there are very NCLEX-like in nature to help you practice. We have NGN style questions. We have classic style questions that are there to help you test your ability. We also have one of my favorite times of the month is our 3-day live. So generally, unless there is a holiday or something going on, the first Wednesday, Thursday, Friday of every month, we have the 3-day live review. Now, the 3-day live review, I like to think is like a whirlwind of nursing school in 3 days. Now, we're not able to cover everything, but we teach those high yield topics, those things that you're really going to see on the NCLEX. We talk about test taking strategies, about test taking anxiety. You're going to hear from leaders in the industry on all aspects of nursing, from endocrinology to burns to labor and delivery, maternity to endocrine and pharmacology all along the way. So this is, like I said, my very favorite package. If you are a RN, you can scan the code on the left to see what all that looks like. If you're a PN, scan the code on the right. And we hope to see you using these tools for better success. All right, well, that has ended our time together. I am so thrilled that you have joined me this evening. Whether you are loving maternity or maternity is kind of a for you. I'm glad that you are here. I'm glad that you have put in the effort to dive into a case study with me. My goal is not that you're going to become a nursing expert in this field, but that you feel more confident in the concepts that we discussed today. So I hope you found this beneficial. We are wishing you well. We are cheering you on, and I hope to see you back on Monday for our next free webinar. Have a great weekend, everyone.